Alrighty, so we'll go ahead and start. It looks like we got everybody here. First of all, thank you everybody for joining. Thank you to the Mercy Program for being willing to spend some of their night with us. Just to introduce ourselves, my name's Arpam. I'm your National SAOAO Secretary.
My name is Jim. I'm a third year at TCOM.
So this is the first of the open house series. We're really lucky to have Mercy. They brought a lot of people here who were willing to answer questions. So just a little bit about the format of how we're going to work with this. First, we're just going to have Dr. Miller and Dr. Phillips talk a bit about their program, after which we'll open it up to Q&As. Jermaine and I will ask some of the more frequently asked questions that you guys have been having, just so that way we can get those out of the way, and then we'll open it up to you guys to ask questions. We'll go ahead and let the residents introduce themselves. We'll ask them a lot of the frequently asked questions, and then we'll open it up to you guys as well. So we'd love to hear from you all. If you have questions, please try to unmute yourself and ask the questions instead of throwing it in the chat. Just gets a little bit hectic and hard to know the hierarchy of who asked what first. So we'll go ahead and get started then. Dr. Mill and Dr. Phillips, if you guys want to take it away.
Cool. Dr. Phillips is on now. Is that correct?
Sure.
Good. So I'm Rick Miller. I'm the program director in Toledo. I've been in Toledo since 2015 as a program director / associate program director, and it's kind of an interesting story. Well, I'll say why I say that, so I'll let you know that in a second. I trained in Toledo maybe 150 years ago. After I finished my training, I went to Indiana for 15 years, and then I was lucky enough to be able to come back and help the program during the beginning part of the single accreditation process. And that was the whole reason for coming back. The program director was at the point where he was thinking about retiring, and he was nearing 80. The program director I took over for was the first board certified DO orthopedic surgeon in the U.S. and a real legend in our field. He was, I think, at the point where he really wasn't interested in going through the single accreditation process and the work it was going to take to have the program kind of get through that process. So he was looking for somebody to come back and help with that. And I was lucky enough to be able to be at the right time to come back and do that. So I've been on board since 2015. The ACGME process has been kind of arduous, but exciting, and kind of has challenged us to become a better program, even a better program than we were before. And this program has always been a very strong program located at a level 1 trauma center. We take 3 residents a year. We have a very strong exposure in I think just about everything, but especially trauma, an adult recon exposure, sports medicine, foot and ankle, shoulder. Our residents get to enjoy doing pediatrics both in our place with our recent merging of Mercy Children's Hospital with Nationwide Children's Hospital out of Columbus. They also do 4 months down in Dayton at Dayton Children's Hospital, one of the top 50 pediatric hospitals in the U.S. They spend 6 weeks at the James Cancer Center at Ohio State University doing orthopedic oncology, and that's another world-class rotation. And then 3 months in Cleveland doing hand and upper extremity, which is an incredibly busy service. The residents all do very well on the OITE. This year they were a group of gross underachievers, and they scored as a combined group 98th percentile in the US. The year before, 99th percentile. The year before that, 100th percentile. So we're going to try to get them back up to that 99th or 100th percentile and try to have them not loafing as much as they did last year. And that is a bad joke, sorry. 100% historical first-time board passage rate. So a strong didactic, strong surgical program. The residents don't have a problem getting into fellowships of their choosing. And we do have the rare person who will go out and do general. I think as we go back and talk to residents in the past, by and large, they feel very comfortable after their 5 years going out into practice right away. and don't need the fellowship for extra cervical exposure. They do it because they truly want fellowship experience to hone their skills in one specific area. Kind of a quick synopsis of the program. I'll kind of turn over to Dr. Phillips now if he's okay.
Yeah. All right.
Dr. Phillips is our associate program director. Just a little history since I turned it over and then took it back. He's a graduate of our program. Dr. Phillips was a second-year resident when I came on board. Finished residency, did a one-year trauma fellowship at the University of Kentucky. And then we were very fortunate to be able to convince him to come back and help head our trauma program and help build it. So without further ado, I'll get out of his way.
I know this is like the most annoying question ever, but you can see my screen, right?
We can.
Yes.
All right. All right. It's the presentation, not any of my dirty emails or anything, correct?
No dirty emails.
Not yet.
All right. So without further ado, this is the best I could do with my PowerPoint skills, but this is us. So this is the most flattering picture of our hospital that's ever been created, for sure. But it's pretty cool. The main hospital is here, kind of to the center, maybe to the left a little bit. It's a little bit outdated. Or no, I guess it is. It has our new ER and facilities. On the right side of the street there is some outpatient offices and also our cardiovascular hospital. It used to be a place we didn't go too much, but they moved our trauma ICU down to the whole first floor of there just because it's much better facilities. So we get our steps in by walking across the skywalk there. There's a local high school. It's got their football field and everything in the top right. But like I said, that's the most flattering view you'll ever see. As we said, this is us as well. This is Dr. Miller and myself. We're the two-headed monster that's in charge of this program. And this is also us. I know we got a wide audience, so you may not have any idea where Toledo, Ohio is. But we're kind of in that northwest corner, right up on the border of that state we won't mention. But we've got a Cleveland to the far east, and then Columbus is a little further down. But we got a pretty good area that we pull from as far as patient population. So what we offer, I mean, pretty much everything. And it doesn't always mean that all this stuff is fully in our hospital, and we'll talk about how we supplement some of those things in a minute. But I mean, any given day you could be in arthroplasty, trauma, sports, peds, hand, spine, foot and ankle, oncology, and believe it or not, we even have general cases. We'll kind of talk about that. Again, this nice picture is we have our own life flight crew, so that brings a lot of our more advanced trauma stuff in that we get good exposure to on all your call shifts here. So this is our group. I couldn't Photoshop this to look any better. That's what we got to work with, guys. We take 3 a year. It's 15 total. To the right here is also a great addition to our program. We started adding a research fellow that kind of complements the group, and we'll talk a little bit more about their impact. But that's Sam. He's here for our current year. Our inaugural research fellow actually was Amy, who's, I think, on the call I saw, and she's one of our current PGY2s. And I can't understate what a big impact that was for our program. That was definitely a missing piece for a while. I know some of the bigger programs or just other programs do the chief here a little differently. They may appoint 1 or even 2 chiefs to kind of run the show. But for us, all 3 are considered co-chiefs. They have different roles. Some are more over, say, journal club responsibilities, those kind of things. Some are over the daily didactics, some over the more, day-to-day, managing or vacations and that kind of stuff. But they all are, equal parts and do a really good job kind of steering the ship. So as far as what hospitals we cover, our main ones in town are the 4 ones that kind of have pins dropped here. They're all just around the city, so none of them are too far. You can get from any one of these to the other in, about 20, 25 minutes tops. So it makes it really nice from that standpoint. We meet every morning at St. B's, which is kind of in the middle of downtown. They round, they have our morning didactics every day, and then everybody kind of scatters and goes their separate way based on what rotation or what cases they're covering that day. But St. V's is our home base. St. Anne's, Perrysburg, and St. Charles are the other ones in town. The other ones we have listed here are Dayton, which is where we get our children's exposure, or excuse me, our peds exposure. Like you said, we partnered with our nationwide children's in Toledo, so we still have 2 full-time peds attendings in Toledo that you would get continued coverage when you're here, but we also do 4 months of a dedicated nothing but peds rotation down in Dayton. It's about 2.5 hours, 3 hours maybe south of us, so you get housing while you're there, and the call burden's not too bad. You get a lot of chance to come home on the weekends and other stuff like that, so it's not like you're across the country, but we also admit it's not in the backyard either. But we think it's an experience. It's very much, well worth a little bit of displacement for short term. The other thing we've got is we do our oncology rotation at the Ohio State University in Columbus. It's a multi-week experience with one of the best orthopedic oncology centers in the country, and we're extremely fortunate to have that experience. We don't get a ton of oncology at Mercy on most days, which in my opinion is really good because it's not too fun. But you'll get basic stuff. You'll definitely get, metastatic lesions that have pathologic fractures and stuff that we'll for sure treat. I think if we find anything that is, potentially a primary bone tumor or something that's a little more nasty, we have enough sense to work that up and send it out. But, if that's something you're interested in, you still have an outstanding exposure to Ohio State. And also, we have a really good hand rotation over in Cleveland, kind of a lot like our Dayton experience. You get housing. It's maybe 2.5 hours away, but you get to dive in with an outstanding crew there and then really get into the nitty-gritty hand. Again, a lot of our attendings do hand, whether it's fracture, whether it's tendon lax or whatever it may be. But there you'll really get into kind of the depths of it. So some of the strengths we asked around, and this is kind of the first things that popped off our residents' heads, but we get a very wide variety of fellowship interests, and everyone is successfully matched and usually very high. So that's a really good pedigree of our program. We've got really strong autonomy, and we can kind of talk about that. I got a couple slides that talk about how each year is structured and what we focus on. I think as a whole, we all get along really, really well. And I'm biased. I'm from this program, so I'm used to a relatively smaller program. But I've done out rotations or fellowship at a different place with a lot bigger programs, and you can just get the sense that it's just not quite as close knit of a program. And I'm not knocking that at all, but if that's something you're interested in, I think a smaller program is definitely worth looking at. We have a really good sense of progression. The responsibilities certainly increase year by year, and I think we have a kind of a unique way of doing our chief year. We almost treat you like fellows or junior attendings to a degree, where you guys run the day-to-day and decide how things go. If there's any question, you guys are our quality control people every day that hopefully there's no issues that have to get to Dr. Miller or myself that chiefs have already kind of addressed and handled in such a way that we don't have to intervene too much. And that's something we intentionally build in and build that responsibility. And it may sound kind of trivial or almost like we're passing the buck, but I promise looking back, that was an extremely valuable experience. And I'm so glad that we continue to do that. Our board performance has been outstanding. We've had no issues there. We've consistently been in the top percentage of test takers, which has been fantastic. One of my classmates got the Bob Green Award for the top scorer, that year across the country, which was awesome to be paired with him because there was no way I was winning that one. But that really comes down to our didactic schedule. I know a lot of places take a half day and carve out, and they do 3-4 hours of didactics in a row, and there's some merit to that, but we've always taken it a little bit different. We do 1 hour of didactics from typically 6 a.m. to 7 a.m. Monday through Friday. So you just have an hour of a single topic. So you get to dive into sports on, let's say, Tuesday, Wednesday, maybe our Miller review for our board prep. Trauma, for example, we do every other Friday. And that can be anything from a cadaver lab to going over journals to a presentation. or whatever it kind of needs to be, a sawbones lab, something like that. So it was a little rough just because you had something to prepare for every single day, it seemed like, but it was also, digestible amounts where you weren't just completely zonked out after, an hour and a half of hearing about a single topic, and you weren't listening the other hour and a half in the afternoon. And it's also structured in a way that you don't have to miss cases. There's not too many cases that start before 7 a.m. That's for sure. So there's a lot of reasons we do it that way, and it seems to work really well for us. This is a shot of our morning sign out or didactics and what we call our library. Everybody kind of gathers and reviews the cases from the day before or the consults overnight. And then again, that kind of flows into didactics before everybody heads out for their surgery stuff. The other thing we have that seems to be more of a rare thing as the years go on is a dedicated resident clinic. I don't know if you can see my cursor at all, but on the left, I had to point out Fortunato with that blue arrow. He's just so excited and benefiting and learning so much that he couldn't help but stand out. So it's for the residents, but it's also a great thing for the med students. The bottom picture is when we have a lot of auditioners in around. That's one of our chiefs kind of really breaking down and going through some stuff. So it's a really good time for some clinical education and maybe a good time, especially for students that can ask questions that maybe in the heat of the moment in an OR case or something is not the right time. But that's a really good time to go through some of that stuff and learn. And for the residents, it's a chance to kind of practice being and attending, as maybe corny as that sounds, but you get to have these patients, you make the decisions on how you want to work it up or the treatment or that kind of thing. And it's not that it's not supervised. You can see Dr. Miller on the left side picture there, kind of entertaining for it, but it's something that we expect you to have a plan and have a strategy on how to treat this patient and take ownership. It's not something you just sign out to us and then wait and be told what to do next kind of thing. So it's also something that's just very, very valuable as far as prepping you to go out on your own and kind of have that confidence of having this experience under your belt. So our weaknesses, I think it's not fair to you guys if we don't at least address these. I think historically, these are the things that either I've heard or other students have told me that we've been criticized for. And, maybe in the past it's been a little more true, but I think we're going to go through some of this. One is that we don't accept any women, females, whatever. That's obviously not true because we have confirmed two in our program right now. The other thing is we only take DOs. Yes, we're historically a DO program. Everyone knows that, things have merged and we're open to finding the best candidates that are the best fit for us. And to prove that, we've got 3 of those unfortunate MDs right here. I would say that, we still strongly promote our DO heritage and we respect that. And it's not that we're actively trying to get MDs in here necessarily over DOs. I mean, again, we're a DO program historically, but we will take whoever is the best candidate and the best fit for our program. The other thing is our academics. We're not necessarily based at the university of whatever, right? So we maybe don't have the same academic backbone and culture and those kind of things. And again, historically, fair enough. That's a fair criticism, especially from as recent as when I was here. But since July of 2020, and the reason that date's relevant is just because that's when we implemented our resident fellow or research fellow. We've had 40 publications, 27 presentations, and 1 book chapter. And there's many more things kind of in the works right now, but that's what's been out there and published and have made it through. And those are some pretty outstanding numbers for a place that's quote unquote not academically strong, I think. The other criticism is delayed exposure to some specialties. I don't have any cool graphics to make that one go away. I think that's a fair assessment to a degree. For example, oncology, right? If you thought that was really where your passion was and you wanted the most exposure possible, I think you're probably a little off and you might need a psych exam first. But hey, if you pass that and you decide you want ortho-onc, you're not really going to get true onc experience until your 4th year. If you came in knowing that and you told us that up front, obviously we would do what we could to get you some exposure earlier, or, still make it very much worthwhile. But, some of those more rare things, I would say that's true, that maybe at a, Ohio State or bigger center, you'd rotate there early. But that's just one of the trade-offs, right? It's just being honest. So we're going to break this down year by year. And this was, again, feedback from the resident's perspective. So the life of an intern is what I could summarize as you basically learn the ropes, right? You've learned how to be a physician. You've made it through med school, but you don't know anything about being an orthopedic surgeon yet. So it's kind of starting over to a degree. You're taking call. That's almost entirely a buddy call, if you will. There's going to be a junior there with you towards the very end of your intern year. Based on your progression, the intern or the junior with you may decide to leave you alone and let you be the big shot on call and manage things, really as a way just to prep you for your second year, when you're going to be the only person in that hospital level 1 center taking call. So it's not dumping responsibility on you. It's really gifting you that when you still have a little bit of a safety net to make sure you're ready. But for the most part, you're taking call with the junior for the majority of the year. You're the one, getting the pages. You're the, get to make those decisions, decide how to handle things. And as your year goes on and you prove yourself, you get more and more responsibility. You begin operating. We're not one of those programs where your entire first year and a half, 2 years, you're going to be just doing floor work and you're going to be in clinics. And, yeah, that's part of it, but we really, really want you in the operating room. It's a big part of our program and something we want to continue. The other thing is just learn how to manage the list. It's our patient list. We live and die by that thing. It has to be accurate at every minute. We get as critical as criticizing the punctuation or capitalization sometimes, but it's something that you will learn to take obsessive ownership of, and it's fun. The other thing is you do have some off-service rotations. We do 6 months of orthopedics and 6 months of off-service, and that's just because that's the most they'll allow us to fit in ortho into the year. We've tried to structure those off-service rotations so they're still somewhat beneficial to you. You get some like vascular surgery, you get some trauma, general surgery trauma service, which is really relevant, and some radiology time, stuff like that even though it's quote unquote, off service, it's something that hopefully you can still, learn from and at least make you a little better as you go forward in orthopedics and forget all the other medicine stuff. On the bottom right, we go through a book every year. It's called Extreme Ownership, and it's just something we do on top of, orthopedics to talk about things that apply to being a better person and a better leader in the hospital. And hopefully we try to tie it into even just family life or, whatever else you got going on too. But it's something I enjoy. Hopefully it's not too much of a burden, but it's a little change of pace that's hopefully still beneficial. Here's a picture of one of the many cadaver labs and different things we do throughout the year. It's called the Douglas Lab, and we have an outstanding supply of cadavers, usually 2 at a time, throughout the large majority of the year. Sometimes those are for structured, industry sponsored things where a company wants to come in and show us their newest product or, an external fixator or scopes or those kind of things. And the rest of the time it's open for kind of free access. We just contact the person in charge and just let them know we're going down there and what we're going to do and that kind of thing. And I can tell you, as a fellowship trained, I'm 4 years out on top of that, and I still spend a lot of time in the cadaver lab. It's an absolutely outstanding resource, and I didn't realize how lucky we were to have it until I've gone to other places or, talked to other places. And this is honestly a pretty rare commodity, and it's unbelievable. So I'm very thankful for that. So the second year, this is really where the rubber meets the road, and it's your trial by fire. You increase your call responsibility. So you're taking isolated call, and between the 2s and 3s, the 2s take more of it, right? It's just a hierarchy thing. I think it's still manageable as far as not, getting you burnt out and abusing it or anything like that, but it's a lot. You increase your operative autonomy, right? So there is some trade-off. You're covering cases a lot of times by yourself. You're expected to know how to do things, and You know, a lot of times we encourage you to have the mindset, if the attending would drop dead and you needed to finish the case by yourself, you better be ready, right? So there's just a lot more responsibility. This is really when you start learning and getting in those situations where you really learn how to push yourself, but it's outstanding. Then we also have increased didactic responsibility because you've made it through your intern year, and we kind of trust you to actually put together a good presentation, do some research, and we start to actually listen to your opinion at this point. Anatomy is something we do uniquely for our PGY2s. So we wait till after the OITE exam in roughly November. And then there's a dedicated body that's purely for the PGY2s to go through, and we have a whole protocol on everything they go through, and go through surgical approaches as well as just gross anatomy type stuff, and it really helps you in your OR exposure and that kind of stuff as well. And then we also have articles and things that we present in our didactics that you kind of get the point. We also do fun stuff. So just because you're in the OR doesn't mean it's all gloom and doom and all that kind of stuff. That's me on the left, and I had nothing left to do other than kind of screw around for a picture because the chief and the second year there are doing such a good job that I just kind of didn't have much to do. So we very much believe in the residents doing what they're prepared to do. And yes, they're supervised, but it's kind of our job just to stay out of the way if you're ready and prepared. And then on the right side is one of our journal clubs. We do those pretty frequently. It's really nice to kind of just gather outside the hospital and, if nothing else, get a good dinner, but also get to look at some of the newer products or have a good discussion and just kind of socialize a little bit. So it's been really nice. Third year, you're the quote unquote senior most junior. So you're the one that's going to kind of be in charge of, morning rounds, that making those decisions. You get a little less call burden compared to second year. You get your first pick of the call as well. Just again, the hierarchy. You also have that first out rotation down to your pediatric exposure. And everyone usually has nothing but great things to say about that place and how much you learn and you grow and that kind of stuff. And we take it kind of serious because you're representing our program to the other residents that come through that program from different places. And, we've always had great feedback from the attendings down there about how our residents have performed. So it's really interesting. Again, more operative autonomy. You've proven yourself, now 2 years in a row, and you just get to do more. And the attendings have spent more time with you, so they let you do more. So it's really nice that you just kind of keep that momentum going. And then fourth year, we've called that our ghost year. So it's not that you're not around at all. It's just this is where, a lot of that away time comes in. You've got your oncology rotation, your hand rotation for a couple months. And then also this is when, fourth year, when you interview for your fellowship match. It seems kind of early. That's just how it works for orthopedics. So again, it's just more of that kind of necessary, timeout. But it just kind of ends up being that year where, you're kind of away. The fourth years also don't have in-house call responsibility for us either. So that's where they kind of get lost in the shuffle a little bit as well. But again, it does not mean you're not operating, you're not participating, you're not learning and growing and doing things. It's just kind of the way our fourth year rolls. And then these are not our chiefs at all. Our guys couldn't manage to get me a group picture. I guess they were all so hardworking. They don't hang out together. But you literally run the show, and we talked about it earlier. You are literally responsible for everything that happens in that program for all 15 people. It's a lot of responsibility on top of your already, expectations of being a resident and still learning and growing and board studying eventually and that kind of stuff. But again, like I said, it's a irreplaceable experience and something I'm so glad that we have. And you learn more than just medicine. Because eventually you're going to be out leading an OR, you're going to lead your group, potentially you're going to lead your clinic, and you've got to learn how to handle yourself with those responsibilities. So there's the most recent crew of chiefs we've got. The other thing chiefs do is you lead by example. I mean, I can remember as an intern, you have that look almost like a kid has for their dad almost, to where you just think they're, 10 feet tall and Superman, right? I mean, it just seems like the chiefs do no wrong, and they somehow always have the answers, and they always are better, and they just kind of keep going. So this is one of our fives, and Jay, who's a current 5, is a 3, I believe, on the ride. So they always look up to you. So watch what you do, The other thing we have is the city of Toledo. So when we actually unchain you and let you leave the hospital, you can run around Toledo. I think one of the leading things people you try to sell you on Toledo, they say it's only an hour away from Detroit. There's a big airport there, but I think that's the most ridiculous thing to say about this city. Just horrible. There's a lot of stuff to do. Downtown is really, really turned around. They've really put a lot of money into that. There's some nice places to eat. There's bars. There's, all that kind of stuff. The picture down here, the Mud Hens, we have a semi-professional baseball team and a really nice facility, and it's really cheap, really easy to get down to. So it's really nice in the spring and summer. The Walleye is the semi-pro hockey team, which same thing applies. It's a lot of fun. There's also concerts and everything, all the major, people come through, different shows, all that kind of stuff. A lot of our younger residents or maybe single people, a lot of the apartments and condos and stuff have been renovated downtown. So they've moved into a lot of that stuff. We also have some really nice, suburbs around if that's what you're into, or if you have a family, those kind of things, good school districts. A lot of breweries, all that kind of stuff that we've posted here, the casino, if you're down to losing that resident salary. And then an outstanding metro park system that it's just that it's fantastic. So there's a lot to do outside the hospital, and yes, there's a chance to have a life outside the hospital. And Toledo's a pretty darn good place to do that. So I know there was kind of some questions that wanted to be brought up already, and then obviously we'll have some time for any other ones to come up. But anything burning anybody's mind right now?
Thank you so much, Dr. Phillips. So like we said, we're just going to ask 2 or 3 of the most frequently asked questions that we've seen. Then we'll open it up to you guys. The way we'll run this for the next half hour or so, we'll let the PDs and the assistant PD talk about any questions that they might have for the next 15 minutes. And then we'll let the residents introduce themselves and answer any questions for the next 15. So start us off, one of the most basic questions you'll probably get from everyone. What does a strong residency candidate look like for your program specifically? Can you talk about, on an application, what you guys tend to value more when you're reading through them? What stands out to you the most?
Yeah, it's becoming more and more challenging to figure out who a good candidate is, right? There's so many. Last couple of years, the number that have gotten in is about 50%, right? So it's a challenge to know who the best candidates are. That's a good thing and a bad thing. The applications are ridiculous. The numbers are incredible. The class ranks are incredible. Everybody has learned that something that sets you apart from the other candidates is a plus and might get you in, research and things like that. And so people have really taken that to heart and are working earlier on research and other things that might be things that are unique qualifiers, I guess. For us, it's all about fit. You're going to be with us for 5 years. You're not going to be with us longer because we can't tolerate you more than 5. You got to be able to get along with everybody else. You have to be able to fit in. We like strong work ethics. We like team players. We like people that are going to back each other up. If you have a colleague who needs your help, you jump in and do it. We take to heart that the patient is the center of all that we do, and we look for team players that help us do that.
All right. And then second question. So as program administrators, what are you most proud of growing or establishing while you've been at Mercy? And then what are some aspects that you're hoping to work on in the immediate future?
I'm going to briefly talk about that, but I'm going to pass that off as quickly as I can, just because I think Dr. Phillips has got a really unique perspective. He was a resident here when I got here. He was a PGY too, as I was kind of starting my in my role, and he's seen a tremendous amount of change. I mean, we're not even in the same building that we were in when I first got here. The residency has completely changed. It seems like a real department now, as before it was a little disjointed. The research change has been tremendous. The addition of the research fellow has been an enormous boon. I'm proud to say that we're on our third research fellow now. The previous two both matched in the programs. And that match rate for somebody who doesn't match the first time is right around 7% the second time. We've got a 100% match rate for our research fellows. We're very proud of that. So, I mean, there's just been a lot of change. Dr. Phillips, things that I haven't thought about that you can think about from both a resident and a faculty attending standpoint.
No, I think the biggest change by far has been just the ramping up of the residency and just giving the research and giving it the resources we needed. I mean, we were so busy as residents day to day. It's not that nobody had interest in it or nobody cared or anything like that. It's just that it was so hard to do without that. So that's been the biggest change for good. And I think the thing I'm most proud of, as corny as it sounds, is just watching everyone come in when you know nothing. I mean, and seeing them graduate as people who are people that I would take their opinion and let them treat my patients. And, we just had a recent grad that did general. And obviously he's fresh into practice and still, has questions. So he texts some of us all the time, but most of it's just to say, yes, you're right. And yes, you're fine. Calm down. It's not that he has no idea what he's doing. It's just, and genuinely, I consider him a friend. I mean, we still send stupid jokes back and forth. We, still hang out. We, do stuff like that together. So, I mean, there's not a resident that's come through here that I don't consider a very close friend. And just seeing the people that you care about and you love progress and do better and, make us such a tremendous improvement in their lives and such big success. And I mean, as a physician, as a surgeon, you're going to have the life you want and be very comfortable and you'll be very, very fortunate. And I just think seeing those people year after year achieve that level of success and happiness is just so rewarding. And it's one of my favorite parts about being, involved in a teaching program, that and just, absolutely stealing the souls of the residents when they mess things up,
All righty. So at this point, we're going to go ahead and open it up to you guys. It looks like we have a pretty good range of students here from all different years. Just go ahead and introduce yourself and then we'll take it from there.
I'm Zac Fulton. I'm one of the PGY 5s here.
I'm Hunter Ostlie. I'm one of the PGY 1s.
I'm Amy Singleton. I'm a PGY 2.
You guys have any questions?
Yes, I have a question. So, hi, I'm Hans von Niederhauser, and I'm a student at OUH-COM, Dublin. Okay. So I loved what Dr. Seth Phillips was saying, and I can see a lot about what the team means to you, about what the people mean to you by the way that you're responding. And my question for you, sorry about that light. Okay, maybe that's better. Okay. My question for you is, as a osteopathic doctor, how do you include that in the way that you operate? And by operate, I mean just in general. I'm not talking specifically.
Yeah, no, that's a great question, honestly. So I went to OU-COM or OUH-COM, I guess, as well. And I think if you're asking how do we apply maybe OMM or some of those kind of things, you don't. I mean, could you if you wanted to? Sure. I think what we are uniquely trained in and a skill set that we have to offer patients is mainly in the surgical realm, right? So that's where we focus a lot of our efforts and attentions and those kind of things. And I'm not downplaying OMM by any means, but I also don't really get too worried about people's blood pressure either, because that's just not my place to do so, right? I'm here for surgery, right? And I know that's probably the most stereotypical surgeon answer ever, but I think what I do take from that is still what you're taught as far as the holistic approach, right? And you view the patient as a whole. And I think that's something that is extremely important. For me particularly, I do nothing but trauma for the most part. And I mean, our clinic visits turn into half social work visits, half actual orthopedic follow-up, because they maybe don't have the resources to get their antibiotics. They don't have transportation to physical therapy. They don't have the education to follow through on the simple plans that you printed out for them, kind of thing. I mean, there's a lot of things, especially in trauma, because they didn't get to pick me. They just showed up in our ER, right? They probably didn't get to pick our ER. They just showed up from the ambulance or life flight, right? They didn't pick the best time in their life to take 3 months off work. They just had an accident, or maybe were a victim of something and ended up. So there's just a lot psychologically, as well as on top of their injuries and everything else that may be going on, that just being able to step back and treat that patient as a human and not just an x-ray. It's something I think is ingrained in all of us, just with our osteopathic background, that maybe you don't even really think twice about and notice. But I think some of my friends that have gone through allopathic programs, or other people that we are partners with that are allopathic, you kind of see those differences. And I think that's probably what drew you to osteopathic medicine in the first place. So you've already probably got that as part of your nature. So I would just extremely continue to encourage you guys to have that same mentality and mindset, and treat that to our less informed ND residents like Hunter when they come through.
Thank you, Dr. Phillips.
I have a question. My name is Gabe Scarbot. It's for Dr. Miller and Dr. Phillips. With the addition of the research fellow in the past few years, what do you guys kind of hope in the future to add to the program? In the next few years, 5 years, whatever. What do you guys kind of hope to have in the future?
I'll start out. I'm going to answer that by kind of revisiting the past a little bit. So when I first got here, I think our orthopedic department had 3 or 4 people in it. I don't know how many providers we have now, more than fills a page with, wall of shame photos on it. We have 2 strong traumatologists now. We've got arthroplasty covered. We've got a foot and ankle specialist that we've brought in. We have a shoulder and elbow specialist that we brought in. We continue to try to hand the Nationwide Children's Hospital collaborative agreement with Mercy Children's, has evolved. I mean, it's changed a ton. We have a continued emphasis on building a highly effective, world-class multi-specialty department. We're going to continue to try to bring people in. We're going to continue to try to bring past grads back to help us with that. And then I can't imagine that we're not going to continue to have a research fellow for, the next 150 years. It's been such a good part of the program for us. The research fellow helps us lift the heavy weights so we can get things done. Dr. Phillips, other things you can think about?
The only thing that would potentially see coming in the next, several years would be, like we discussed, we keep adding attendings and more cases, and there's the potential of increase in the class size. I'm not saying that's coming or whatever, but that's kind of always on our mind, like he said, as we continue to recruit high quality attendings and add cases and volume and those kind of things. I mean, we want you guys to kind of be at the max of what you can handle from exposure and, just getting the reps in, but we also don't want to leave cases on the table when we just kind of can't cover everything because there's not enough bodies, because there's only so much of us to go around, right? So I think that's a really, really good problem to have. And if you guys are going around, and you know, whether you're in these kind of talks or your audition rotations, and you see a lot of people making it to dentist appointments and, you know, banking hours type stuff. Yeah, it may seem great, but I'd really question, you know, what kind of training and exposure they got at the end of their 5 years, and if they're ready to cut another human being open and know that they're going to make them better in the process, right? So, and I mean, I'm not dogging any programs in particular, but our mindset is much more of that blue collar, show up, get the work done, and you go home when the work's finished, not when the clock reads a certain time, right? So I think that's been our recipe for success, and we're not going to change that. And that's part of what I don't want to change too much about the programs. I think we've got it in a really, really good spot. And, you know, Dr. Jablon started this program years ago, and Dr. Miller's done a really good job keeping kind of true to our ethos and keeping that same mentality and changing when we think we can benefit, but not changing just because, you know.
So we're going to have time for about 1 to 2 more questions for the program directors, and then we'll go ahead and transition to the residents. So go ahead if you have other questions.
Or I got
Sophia.
Oh, go ahead.
No, it's okay. Go ahead.
Just real quick, could you just speak a little bit about the patient population that you guys care for?
I think we cover it all. You know, the trauma exposure is a downtown inner city population, but we have 5 life flight helicopters, things being flighted in from all over. I'm a arthroplasty guy. I have a more suburban practice, and so it's suburban America. We have, you know, one of our sites, our training sites, is a rural site. So we get rural exposure out there as well. So I honestly think we have it all covered.
I mean, I always say trauma is not an accident, it's the population. So we very much get the exact trauma patient you're going to see at most places. But I've had everything from people bringing in a bottle of bourbon to say thank you, or a homemade blanket or food, to, I think last week I literally had a patient say he can't wait till he can walk on his calc again because he wants to fight me. Like he literally wants to box. So I've seen cracked rocks fall out of people's cam boots when they go to show me their foot. So you just never know. But I mean, we get a pretty good variety. And like you said, it's different through the different specialties, just the kind of patients you treat. But like you said, we do have everything from rural to inner city.
You'll get to see plenty of psychiatric pathology as well. You do. I mean, it's especially the inner city stuff. It's sometimes you get to wade through some things that you can't imagine.
All righty. Sophia, if you want to go ahead and ask the last question, then we'll transition over to the residents.
Hi, thank you. Sophia Saraki. I'm a second year at PCOM South Georgia. I have a question regarding the metrics you use, if any, in order to evaluate students or medical students' apps for away rotations. If there's any specific metrics you guys use.
So just to kind of clarify the question, as we're looking for applicants for the program, what things do we use to delineate which people we're going to take? Is that kind of the question?
Yes, sir. Yes, specifically for away rotations.
For away rotations.
As well. Mm-hmm.
Okay. You know, I think first and foremost, a complete application. I think if you don't have a complete application, there are so many good candidates. It's going to be hard to, you know, try to tease through the application and figure out if you're a good applicant or not. In general, if you go to work for corporate America, they're going to choose you if you've spent some time with them, or they're going to look upon you more favorably, or they're at least going to look upon you as somebody they know better if you've spent time with them. So we do place a heavy emphasis on those that have come and spent some time with us. And it doesn't have to be a month. It can be a couple of weeks. It can be a weekend if that's all you have. But if we get to see you, smell you, look at you, you get to see us, smell us, look at us, then, you know, that breeds familiarity. And that's a pretty important part of the process. Everybody gets high scores. Scores means something. Class rank means something. Letters of recommendation mean a lot. And I do a lot of calling to the letter writers to ask them, is this truly your one of your top 5%, or is this your standard letter of recommendation letter? So those are all big things for me. Dr. Phillips, anything different?
How about the patients that are the patients, cheapers, the medical students that are applying for audition rotations, like to come to St. V's?
God,
Is,
yeah. Is that what you were asking more of?
Both.
Okay, yeah. So those traditionally we've done a minimum score or minimum class rank. That's becoming harder and harder to use as a metric. Sorry about the dog answering the question for me. But that's become harder and harder to do. Honestly, I think when you call to try to get an audition rotation, I think we're going to take as many people as we possibly can.
Yeah, I would say just try to, get to the process early. There's only so much space and it does fill up. So, whether it's us or whoever else is the top of your list, I would definitely prioritize it to where your interests are and just kind of go from there. And some places may have something from this week to this week, and the other place only offers it that overlap, and you can't do both. And so it'll be just kind of figuring it on the fly as you go. But I would just encourage you to try to do it early. Most places have on their websites, when they start accepting applications. And don't be afraid to maybe be a little obnoxious, or at least feel that way. If they say their application opens on the 1st of whatever, and you haven't heard back from them by the 2nd or 3rd, reach out, just say, hey, I just want to make sure it went through. Did you get it? Because we've had people that have had that where they sent it in and they never heard anything. And then somehow they contact us and it just, I don't know, got lost in the internets or whatever. But, so don't be afraid to be persistent and check on that, The other thing is, I think a minimum bench press of 225 for the guys and about 135 for the girls is a good start. I'm kidding. As far as residents, I think the one word of advice I'd have for you guys is don't forget that it's a two-way street, right? We are evaluating you, yes, but you should be evaluating the programs every bit as much and every bit as critically or harshly, right? There's tons of programs out there, and you may be a fantastic candidate, right? But if you're not the right fit for us, for what we described, then you're not a good pick here, and you wouldn't be happy here anyway, right? There's plenty of programs out there that I just wouldn't have been a good fit for. This was good for me, and it worked, right? So just like med schools, some of them work, and some of them you're just like, nah, it's not going to happen, right? So don't forget that side of it. I know at the time it feels like such a one-sided experience, but at the end of the day, you put together a rank list too, right? So you get to pick, and however much power that holds, you get to put together your list. So don't forget the feel and the fit and the philosophy that works. And yeah, at the end of the day, you'll take whatever program accepts you, and fair enough. But don't be so overwhelmed and forget that you've got some say in this whole thing.
I'm going to add one other thing. You guys have heard of program signaling. So the best way to signal a program is show up. Best signaling is to be there.
Thank you so much.
Welcome.
All righty. So thank you both so much for fielding all those questions. We're going to go ahead and turn it over to the residents now. We'll let the students go ahead and ask whatever they want to ask. This meeting might run a little bit longer since we started about 5 minutes late, but we'll try to keep it short and sweet and let you guys answer as many of the questions as we possibly can.
Hey, everybody, I've got a question. Aaron Machin, I actually rotated with you all last year. My question is mostly about reapplicants. So I wanted to ask the residents, what is kind of the biggest thing that you all did or you would recommend for a reapplicant as I'm reevaluating and redoing my application? Any one thing that stuck out or you think helped you succeed?
As a reapplicant, I'm sure, depending on where you are during this last year, you have, some places give you limited availability to go on rotations again. My biggest recommendation would be if you are able to get an interview somewhere, whether you were able to rotate or not, at your interviews really highlight, what you've done in the year in between, because, I, at least speaking for our program, I'm sure I speak for a lot of programs, if you're complacent and you're not showing that you're, constantly trying to improve yourself or improve your odds or gain more knowledge in, this field that you want to go into, it's pretty obvious on the applications as well as, talking to you. So that would probably be my biggest recommendation in terms of that.
Hi, everyone. I just wanted to say thank you for having this open house. It's really great to hear from all of you. My name's Kimi. I'm a fourth year applying this year and also the SAOAO president. And I just wanted to ask, do you guys interview non-rotators, and what is your viewpoint on signals for applications?
I'm not very up on the lingo of what a signal is. However, I was one that did not rotate at our program. So clearly we take people that don't rotate. So I was probably, I don't know, one of the first ones, probably not the very first one that didn't rotate, but one of them. And so I showed up at the interview, and my understanding was, if you rotate, you have a much better odd of, getting into any program, let alone this program. And so, but, like we talked about, fit is a really big thing. And when I had my interview, I felt, at least on my end, that there was great fit. I'm not sure how they felt the same way, but, I felt it was a good fit. And, I think, it just kind of proves that you don't absolutely have to rotate. But, if things work out and, you answer the questions and we realize, hey, this is a person we could totally get along with and work hard with. And, like they were talking about your letters of recommendations, things like that, your odds are as good as anybody else.
I think one thing we've also had is people, they just come for a weekend or just a couple days. If you have time, you might not have time for a whole month or 2 weeks, but even if you just come for a weekend, it kind of shows that you're more interested in us. You took that time sort of out of your schedule to come and see us. And then it helps with the fit because we have a weekend, a few days to chat with you and see what you're like in, real life.
I have a question about for the residents. My name is Antonio. I'm one of the M3s at PCOM. I was wondering on what for residents, how did you feel about family planning during residency, and if that's had an impact when you were choosing programs?
In terms of family planning, in terms of like planning to have kids like during residency, yeah. So I mean, I have 3 kids myself, and I'm probably the 4th one for my wife. But basically, I mean, my kids range from like 9 months old to 5 years old. I had a very young one when I first started, and then I had one during my 2nd year, which is not very arguably the hardest year of all of them. And not only that, I had my kid during anatomy, which is probably the hardest of the hardest year. So I think it's very possible. I think in terms of family planning, you're going into a specialty that is, you're working a lot of hours and, you're working hard all the time. So you kind of have to have that, on your mind, and you need to figure out how to prioritize things appropriately and manage that on your own, unfortunately. But there's a lot of very good support throughout our entire program, whether it's attendings you work with, other residents, tons of other residents in our programs have kids. So it's definitely something that's doable. But I also think it has a lot to do with yourself and how you can prioritize things. But, it certainly helps having, a wife and family that are very supportive. So I think, in terms of our program, it's definitely something you can do. I don't know if that answered the question very well.
I'm going to take a quick poll real quick. Help me, Zach. So as the 5 years you have kids, we have one other 5th year that has a kid on the way. How many of the fourth years have kids?
Fourth years do not have any.
No.
We have a bunch of dogs.
Yeah, they're all kids. The fourth years are kids. Third years, how many have kids?
Two of the three, and one has two, and the other one has 3 or 4.
Yep. How many of the second years?
None of us, but my 2 classmates are actively family planning.
Yeah.
As far as I know.
And then first years, how many have kids? None yet, right? Yeah, but I mean, that's a sizable part of the group. It's got to be close to half that have children. So it's families are part of what we are.
Yeah, I think when I first got here, I was like, there was maybe, I think Milo and myself were the only ones with kids, and then within 3 years, it was like half of our program had kids. So
COVID happened.
Yeah, I guess it got really easy for a little bit, something like that.
Yep.
I mean, the other thing too is I'm not telling you to have kids or not, right? That's up to you. But if you think you're gonna wait for residency and then life just gets better and you have more time as an attending, like, you are wrong. So I would just say, if you're gonna have kids, don't be afraid to do that during residency, because it does not get easier. It doesn't get slower. You just get more responsibility and that kind of thing. So, go for it. I wouldn't worry about that. And like I said, I think our program is very, conducive to doing that. We're very understanding and we encourage it. I mean, like I said, we're a small family ourselves, and we get excited when that group grows.
Absolutely.
You guys have been talking a lot about culture and fit. It'd be great to hear from the residents kind of what you perceive the culture as, and also when people are rotating through, what really stands out to you guys? What are values that you see in people rotating through that make you want them at your program?
Yeah, so I think we touched a little bit on it. We're kind of like a blue collar, hardworking bunch, but we really like to have fun. We give each other a hard time. I think, the camaraderie is one of my favorite parts of, all of us being together. A big group of us, almost all of us, get together at sign out every morning. We discuss the patients, we go through all that stuff. But, after all the seriousness, like, we joke with each other, poke fun at each other in a good manner. And, that's the stuff that, like, I'm going to remember for years, and it builds a relationship. And, we all get up, at least I do, get up in the morning and love coming to work and seeing the people every single day. I mean, if you don't get along with the people you work with and you have to see them every day, I mean, that's tough. And I don't have an issue with that. I don't think a lot of the other ones do either. So I think, it's a great culture.
I think when we have rotating students, when they take call with us, we just kind of look at, they're always available, they're eager. If we ask them to help, they are willing to help or ask questions if they don't know. And then on weekend call, we're basically there 24 hours. So we spend a lot of time together, we'll have lunch and dinner together. We don't necessarily need to have all this same exact interests, but if you can just have a good conversation, kind of, talk about things you've seen, or even just talk about, like movies or your family or anything like that. We just like people that are friendly, people that work hard, kind of just get along with. That's why it's nice to have you guys come in person.
All right, I've got another question. I've loved the conversation and the questions, and especially the talk about family. So for me, next steps. What would be next steps for different years based on, like, we want to explore more, we like what we've heard, and what are the next steps for us? Like, are you okay with us coming out and visiting? We're just dropping you a call. I mean, we've definitely got your website we can go to. What do you offer, and how flexible are you?
I think we can give our phone numbers or emails and you guys can contact us. I think we personally before had students have texted Dr. Miller and then they come out for a weekend just for a few days. So it's kind of up to you. We leave it in your hands what you want to do.
Wonderful. Yes, I'd love that. So any contact point is great for me.
So for the residents, if you will, if you want to, go ahead, put your phone numbers or emails in the chat. And then that way you can just go ahead and see that and individually text them on your own.
I mean, you don't have to wait until your audition time 4th year. I mean, yeah, obviously it's carved out and it's a great time for it. But, if there's a program in particular, whether it's us or anyone else, and you have time, a long weekend or something else where you can go. I mean, there was a resident that just graduated, I think 2 years ago, that I can remember him. He went to a different school, but he lived in Michigan, just kind of across the border. Or he was in school in Michigan, excuse me. His family was pretty close to Toledo, and there were several occasions where he came and just spent a long weekend with us, or spent a week with us, and just, kind of had that audition role, but not quite like, on the hot seat yet. But it was something we for sure knew his face when he came around. I was like, oh, that's Dave. Like, how you doing, man? We like you. You did a good job. And then he had, a huge, leg up when it came time for audition time, right? So, I think obviously we're a level 1 trauma center. There's residents in that hospital 24 hours a day, every single day of the year. So are we accessible? Absolutely. Obviously people are posting their contact information there, and we're serious about it. If you want to come see us, you want to come hang out, we'll be there. That's no problem. So, take that as far as you want, but we'll be there.
Just to follow up on that, reminder that this is being recorded. So we're going to post this on our YouTube channel. Furthermore, we'll take a lot of these contact information. We'll make sure that it gets out to the students so that you have a way to access it. Also, the SAOAO website does have a tab made by QME and some of our other board members that has all the contact information for every residency program, their program coordinators. So all that information is definitely out there. We probably have time for 1 or 2 more questions. We don't want to keep them too long. We know they also have lives to live.
Hey everyone, my name is Zach. I'm a 4th year at LMU DCOM. I just wanted to ask the residents kind of what is, cost of living look like there? Do most residents buy houses, rent houses? How do you feel?
I think it's kind of split. Quite a few people have bought houses and then quite a few rent. I think some of the younger residents that don't have families yet, they kind of rent apartments or condos. And then a lot of the older residents with families, they got small houses. But everybody lives pretty close, within 15 or 20 minutes of the hospital. So it's very easy to get around. Dr. Phillips said earlier, all our hospitals that we go to aren't very far from each other, except for the out rotations. I've lived in quite a few places now, just moving around for college and school and stuff. And Ohio is very affordable. Our resident salary is public info, but that's it's very easy to live on. And I think a lot of the people with families too, they do decently well.
Yeah, there's a there's a lot of outlying, very safe, family-friendly areas. I know, like, when I first was going to move up here, my wife told me that this place had a nickname like Butt Crack of America or something like that. And I really feel like that's not true at all. It's very nice. There's a lot of very nice places around that are, 15 minutes away from the inner portion of the city. And I was thoroughly surprised. So you can find great, safe places that are very affordable and close to your work too. So that was very important for me, is finding all that stuff for a family and not having to drive 40 minutes to work in the morning either. I drive like 12 minutes to work in the morning and live in a great area. So,
and they're making lots of the areas nicer. Like, there was one area across the river that used to be just kind of like an empty lot, but now it's like this beautiful metro park with like a restaurant and like a day bar there and everything. It's very nice, apparently.
Oh yeah, I've been there. I took my family. It's awesome.
So things are getting upgraded.
I will supplement that question with, has any of the residents lived in a place where the cost of living was lower than Toledo?
Yeah, that was definitely Fargo, North Dakota, which that's a cornfield.
All right, Fargo, that's cool. Anybody else anywhere else?
I think Arizona was about equal to here.
Really?
Yeah. But I was like in the suburbs of Arizona, like Glendale, so not downtown.
Gotcha. Cost of living here is, I think, is ridiculous. It's awesome. It's very affordable. One of the things I love about Toledo is I live at the far southwest suburb. If I want to make a concert downtown Toledo at 7 p.m., I can leave my house at 6:20, go downtown, park for $10 or less, grab a beer, and be in my seat before they start. 40 minutes. It's crazy. I love it.
Alrighty, I think we have time for one more question and then we'll let them go.
Well, if there aren't any other questions, I'll add that I plan to attend the upcoming Academy meeting. Somebody had asked in the chat if anybody was planning to attend. I'll be there. I'll be there for the residency fair on Friday. So I'm happy to meet and talk with you guys in person if you're around.
Alrighty, well, if there aren't any more burning questions, wanted to thank you guys for coming on here. Like they said, they'll be at the residency fair. We hope to see a lot of you guys up at the conference too in a couple weeks. And if there isn't anything else, everybody, please feel free to go ahead and sign off. And then everyone from Mercy, thank you so much for your time. It's meant a lot. We'll let you guys know when this gets posted, and we look forward to hearing more from you all.
Thank you guys, and good luck.
Thank you.
Good luck. Thank you guys.